So students, this week actually we are discussing hypertensive disorders of pregnancy, and today I'm going to be discussing on one of the disorders, the complication of hypertensive disorders, and that is eclampsia in pregnancy. So before I start my discussion, there are many of you who are inquiring about my notes. They want my notes. So a word of interest for them, all those students who have subscribed to my classes, my notes are exclusively for those students, but there's also a provision if you want a particular topic to be taught by me through my notes and through my study material, apart from of course the guidance that I provide from various books. You can inbox me and I will let you know how you can do that. For rest of the people who are there in my classes, this is just another class for you, apart from of course the notes that you will be getting. Earlier on I was just giving lectures for one particular topic, notes for the other, but due to the increasing demand I have kind of modulated my lectures along with the classes. So anyways, that's besides the point, but today's topic on eclampsia is going to be stressed upon only about that particular topic, and the rest of the hypertensive disorders I have spoken in and taught in length in my notes. And today I am going to be stressing upon just this complication, which is eclampsia. Now, what exactly is eclampsia? It's one of the most dangerous complications of hypertension in pregnancy, and it is characterized by generalized tonic-clonic convulsions in the body and usually associated with proteinuria and or hypertension more than 160/110. But there are many permutation and combinations available. There have been incidents where the eclamptic fits were only related with proteinuria. In other cases, proteinuria was not present, sudden onset of hypertension in the patient and eclamptic fit. Anyways, this conclusion was drawn that a generalized tonic-clonic seizure in pregnancy would be considered eclamptic until proven otherwise. So, here we are discussing about one of these complications is a sudden onset of generalized tonic-clonic convulsions or coma in pregnancy, unrelated to other cerebral conditions in patients with other signs and symptoms of pre-eclampsia. So actually this is the definition, but yes, tonic-clonic seizures, like I said, it's the language of the book which I just said right now, that until proven otherwise you will be considering it as eclampsia. Now, what is the frequency of eclampsia in antepartum, intrapartum and postpartum? Quickly, there is an incident of roughly 40 to 50% antepartum. According to the bookish figures, it's 38 to 53% incidence in antepartum. 15 to 20% intrapartum, that means a good majority of cases happen antepartum. So there is a good chance of saving those patients. It just doesn't somehow crop up when you're taking the delivery. Suddenly the patient started throwing fit. It happens, but it's comparatively less. And 11 to 44% postpartum. Why is this the figure? Is because if you've taken good, adequate care, if you've diagnosed it on time, if you have that vision in your mind that she might go into eclampsia, you give the treatment. And if you don't give the treatment, the incidence could be almost 50%. So the incidence is so varied from 11 to 44% in postpartum cases. Eclampsia occurring before 20 weeks is usually associated with molar pregnancy. This is one line, but it's a line of big interest. Molar pregnancy, if at all that might lead to eclampsia before 20 weeks. Vice versa, if you think that if a female comes directly at your clinic with frank eclamptic fits, instead of thinking other cerebral conditions, also look forward to this particular diagnosis of ultrasound. You get so involved in treating the eclampsia that you forget about the other possible important thing that you might end up with having a molar pregnancy which did not get diagnosed on time. Anyways, what exactly is the pathophysiology of eclampsia? What exactly happens? Blood pressure body ke andar it's increasing. So what is it? Why is there fits in the body? What exactly is the correlation? So correlation is very simple. What happens in hypertension? Because of the increased in systemic arterial blood pressure, the perfusion pressure also increases. Because the perfusion pressure increases, there is leakage in the cerebral tissue, and that leads to edema in the brain. Apart from, of course, the edema edema is there in the entire body. Have you never seen a hypertensive female with generalized edema, especially pedal edema also, and puffiness in the face? There is edema in the dependent areas of the body. Sometimes it's there in abdominal skin because that keeps hanging down. So you have because of increased perfusion pressure, there is leakage from the capillaries. It is also there in the brain tissue. Cerebral edema leads to the eclamptic fit. Now, what is the pathogenesis? What is the prognosis of eclampsia? Why is it so bad? What exactly happens? So, just this eclampsia is related to placental abruption in 7 to 10% of the cases, which is not less. 10 out of 100 people can have abruptio if they had eclampsia. 1. Acute renal failure of a patient can go 5 to 9%. You can say 5 to 10% roughly. HELP syndrome. What is HELP syndrome? Hemolysis, elevated liver profile, low platelets and so on. That's HELP syndrome. Another complication of hypertensive disorders in pregnancy, which I might discuss in my next class. But currently, I'm discussing one more complication, and that is eclampsia. Apart from HELP, DIC, the incidence of HELP was 9.7 to 20%. These figures I'm quoting from your book Fernando Arias. So even these notes are a lot from Fernando Arias. I've thrown in a few guidelines also in this. It will come later on. But exclusively, mostly the notes are from Fernando Arias, and some of it is also from Williams. So anyways, DIC ka incidence is 7 to 10%. Are you seeing that most of the complications are, the range is not less. It's not 0.1 to 2.2% or 1 to 2%. It is ranging from 5 to 10%, 7 to 10%, 9 to 20%. Pulmonary edema, can you see HELP ka incidence बहुत ज़्यादा है. It is almost from 10 to 20% of cases of eclampsia might go in HELP syndrome. Why are we stressing this? It's because you have to look forward to all these conditions. If you're seeing that the hemoglobin is suddenly going down of an eclamptic patient, and earlier on also her elevation of liver enzymes was more, the elevation was there. That means she is going in that direction. So you have to intervene early. If the platelet count is low, you have to perfuse. If there is hemolysis going on, you have to take adequate care. You might have to give blood, you might have to see, you might have to give immunoglobulin, you might have to intervene with the hematologist as well. Pulmonary edema, incidence is 3 to 5%. Aspiration pneumonitis, 2 to 3%. It could be even more. Okay. Cerebral hemorrhage, 2 to 5%, and even cardiac arrest, 2 to 5%. This is very important because when a patient like this comes to you, you have to tell the relatives about these kind of prognosis as well. She might have a cardiac arrest on table. She might have a cardiac arrest even after the delivery or during the delivery. Even right now, she can also go in for cerebral hemorrhage, pulmonary edema, acute renal failure, HELP syndrome, DIC. There's a very good possibility of all these complications. They have to be mentioned somewhere, and they have to be spoken also. How will you diagnose eclampsia? It's very, very easy to diagnose eclampsia. If you've seen a patient throwing an eclamptic fit in front of you, you will never forget in your life. It's a generalized tonic-clonic seizures. If you've seen an epileptic fit, you will be able to correlate it very well. There's frothing from the mouth as well. There is tongue bite. Then there is tonic-clonic seizures. There is a phase. Tonic-clonic phase. It lasts for 1 to 2 minutes. Facial twitching. And the body then goes rigid. Then there is generalized muscle contraction, and then there is relaxation. This is the phase of a typical convulsion. So first of all, there is tonic-clonic, which lasts for 1 to 2 minutes, followed by facial twitching. The body gets rigid and firm, and then generalized contraction of the muscles, and then there is relaxation of the entire body. That's how it goes. But usually, yes, the suspicion grows more if the patient has got hypertension or proteinuria along with it, to go with it. Now we come to, so diagnosis is pretty easy, isn't it? But when a patient like this comes to you with hypertension along with proteinuria, throwing a fit, there are certain other tests also you should always get. Like the patient has a possibility of going in HELP syndrome, so you should know the profile before also. So you should know the LFTs before, you should know a CBC, so you will get the platelet count test at least before. There is a chance of ARF, so you should have also a kidney function test before. Apart from the other antenatal investigations, these are add-ons. Okay. Now, how will you manage a eclamptic fit? This is very important, and that I'll be taking in the next session.